Okay, I think we are on time. We'll go ahead and get started. Welcome back to the Change Agents Learning and Action Network event, and more specifically to the breakout session number 1, Health IT Strategies for the Changing Environment. Broadcasting live from our host site, the Innovation Center in Las Vegas, Nevada, and joined in various locations in New Mexico, Oregon, and Utah, along with our virtual audience joining us online. We hope to continue what has been felt to be an engaging event and to continue to learn together and move towards action. A few reminders as we get started. Remember to have your action books open and your pens ready to capture great ideas and aha moments during this session. We want you to be prepared to take action on those ideas as you leave the event today. Following this session, we will have a brief break to allow you to transition to the final breakout session. Never mind. Following this session, we will roll right into our action planning and evaluation session. So we'll stay here for that final piece. Please continue to engage with us through questions and comments via the chat window, and for our in-person audience, through the note cards at your tables and through the mobile quick reference codes available at your table as well. Don't wait. Submit them as they come to you, so you are in the queue for our Q&A session at the end. Lastly, a reminder to have your mobile phones out, ready to respond to our live interactive polls. Here we go. So, I am excited about this session as we hope to accomplish multiple things, including enabling you to recognize emerging trends in health IT, identifying ways to align with alternate payment models, identifying strategies for using health IT to improve patient care and process reliability, and planning first steps for implementing health IT strategies in your settings of care. We will approach this presentation in tag team fashion with myself, Wyatt Packer, Vice President of Operations at Health Insight Utah and Director of the Nevada-Utah Health IT Regional Extension Center, kicking off the session with Health IT Trends. Then we will be honored to have Michael Mccarthy, Director of Operations from IPC, the hospitalist company here in Las Vegas, speak to us about his experience having been through the startup of an ACO organization and how that was impacted by health IT strategy. I will then finish off the session, bringing us into some specific items to be considered for using health IT as a tool to support transformation. But as discussed earlier, you, our audience, are the stars of this show. So let's hear from you now. Considering how you, as a change agent, can influence patients and their care teams, respond to this poll about priority areas in your organization or setting that likely involve health IT. Please vote for your top priority area as seen from your organization. Remember to text your responses to 22333 and include the letter corresponding to your desired option. If you've come from a previous session, you may need to retext Change Agents LAN to get resynced with this session. So I recommend you text Change Agents LAN to 22333, followed then by your response. Online folks can also access the poll via the URL listed. So we'll watch live here for a moment as your texts come in. We'll see what rises to the top in priority areas in our communities. Okay, we're getting a good number in our response. So we're seeing, it looks like, that health information exchange seems to be rising to the top of the list, along with patient portals as a second. Oh, patient portals caught HIE. Okay, that interesting look. I want you to consider, make a mental note of the responses from our audience today, because the next slide will show responses from another audience to the same survey question. So this represents a survey from Health IT Outcomes, an online and magazine resource for health IT professionals. They had 179 survey respondents selected at random and are a fair representation of their circulation of IT decision makers from healthcare providers. The majority of respondents represented hospitals and IDNs, followed by group practices, clinics, ambulatory care centers. They had some consultants, system integrators, and value-added resellers included. So the survey methodology was to identify, again, the top trends that they saw as top priority in their plans for health information technology. Now they were asked to also clarify whether the initiative was a top priority, so that's where you see this is their top priority response. So this is in order numerically, so their top priorities were EHR meaningful use. Second was personal health information security. 3 was ICD-10 compliance, followed by patient portal engagement, and so on. Interesting, a little bit of a swap from our current audience, but still these things seem to be important in the process and in the trending of health IT. Interesting for us to maybe consider where our organization is at in looking at our top priorities in health IT. So the next few slides are an attempt to show the progress of health IT and maybe help give perspective to the trends. All come from the dashboard at healthit.gov, the website being dashboards.healthit.gov. This graph shows the adoption rate of electronic health record systems by office-based physicians from 2004 to 2014. The blue line represents adoption of any EHR system and shows the increase from under 21% in 2004 to up to nearly 83% in 2014. The red line is the adoption of EHR with more specific functions being used and reported. This chart shows the adoption of EHR based on practice size, with the lowest rate being with solo practitioners and increasing with the size of the practice. Overall, it appears we have hit critical mass with the adoption of EHR and are moving on to other areas of health IT adoption. This graph represents the electronic exchange of hospital patient data with other organizations and providers. The blue bar being the sending of data, and the purple bar being the receiving of data. From left to right, showing exchange with outside hospitals, outside ambulatory care providers, long-term care providers, and finally with behavioral health providers. I would suggest that this shows improvement in interoperability and connections, but still significant room for increase of exchange. This shows the routing electronic notification of patient's primary care provider upon admit to the emergency room, with the 3 groups being any primary care provider, primary care providers within their system, and primary care providers outside of their system. The variation in blue lines, blue bars being 2012, 2013, and 2014 on the right. Again, this shows progress, but points to the need for connectivity between provider systems as well. These pie charts represent the percentage of total providers reporting on meaningful use stage 1 on the left and meaningful use stage 2 on the right, with a significant increase in percentage of providers attesting to meaningful use that are reporting electronically to their applicable immunization information system in their state. It is recognized that total number of attesting providers has dropped for stage 2 of meaningful use, but those that are continuing are hopefully seeing the value of reporting electronically to their immunization registry. This chart represents the use of health IT by individuals or consumers of healthcare, with the colored bars being the years 2012, 2013, and 2014 from left to right. The groupings being those that sent or received a text from their provider, those that used a smartphone health application, those that looked at any of the medical test results online, and those that sent or received an email message from their provider. The far right representing the percentage that used any of the selected types of IT. This shows that nearly half of all individuals in 2014 used a type of health IT to engage with their provider. Another area to consider in your strategic plans for health IT is consumer engagement. This data is a representation of all 4 of the states in which Health Insight is supporting providers. And it shows the blue bar being the national average for electronic health record adoption, and the orange bar in each case being that state's level rate of adoption of electronic health record information. This data, again, is available as a state summary and other elements of data. And you select the region, which would be West Pacific for all of our states. And then you're able to see those EHR data points as well as the rest of these mentioned on this slide. Recommend that you take a moment when you get back to your office to look at how your state is doing relative to the national trends in health IT. Lastly, I will talk about the Federal Health IT Strategic Plan, which was just recently finalized. Dr. Karen DeSalvo, the National Coordinator for Health IT, said this about the newly finalized plan. This plan will help guide the nation's shift toward focusing on better health and delivery system reform. Federal authorities' investments will seek to implement this plan's strategies. However, she emphasizes, this is a shared undertaking. All of us in this room are a part of that undertaking. As she mentions, efforts in various locations and entities need to come together to ensure that health information is available when and where it matters most to improve and protect people's health and well-being. This slide shows 4 goal areas of the strategic plan. I won't go into detail, but it's there for your reference, and I would recommend you Google the Federal Health IT Strategic Plan when you have a chance and pull that document up. Lastly, this slide just shows that health IT is a building block for transformation. It's foundational for this transformation of healthcare delivery and payment. This is a journey to get to the transformed state that we are looking for, and we're in the middle of that journey. But it's important to recognize the building blocks and build strategies within our organizations to support that. Actually going to take just 2 minutes now to ask you to, at your tables or on the online chat, to discuss the following. What is the current state of health IT in your organization and community? What gaps or barriers exist to progress? And what action steps do you see needing to be taken to support your community's progress? Again, please join with the folks in the room and discuss that at your table. And those online, feel free to communicate your thoughts on this through the chat window. Okay, some good discussion here in the room in Las Vegas. We hope that you've had some good discussion in the other venues, and we'll go ahead and move forward for the sake of time, but I think there's a lot to consider in where our gaps and barriers are in our communities, and maybe what we can do to help move forward the efforts in our community to emphasize the barriers and build on that, on solutions. So I now want to introduce our guest speaker, Michael McCarthy. Mike has had a tenured career in healthcare operations, including with a local health maintenance organization, with an independent practice association, an IPA, in physician practice management for a primary care group, and with a large internal medicine practice, Internal Medicine Associates, which he'll introduce us to. During this time, he was one of the first 90 administrators, around the country invited to the Center for Medicare and Medicaid Innovation for the first advanced learning sessions on accountable care organizations, which he successfully applied for in the January 1, 2013 cohort. Mr. McCarthy has since moved over to IPC Healthcare and Inpatient Hospitalist Group, where he oversees a practice of 52 physicians performing 20,000 visits per month in 4 local hospitals and more than 24 long-term acute care hospitals and skilled nursing facilities. Welcome, Mike.
I hate that picture. Basically, what I wanted to do was kind of go from the micro to the macro, because we've got a lot of different folks from a lot of different care settings. Hopefully I trip over an issue that's important to you. But in large part, it's really about developing an idea on how you approach problem solving in healthcare information technology. It's really about clinicians asking for what they need, IT professionals being open to presenting that information in a way that is reproducible, and taking the blame off the table, throwing it out the window preferably, and just working to improve the information on our patients to the clinicians at the time that they really need it. That's what we're all here for. That's what this whole process is about. My first example is a primary care group. I use them because it's an old school internal medicine practice. Heavily weighted over 65, even heavier weighted over 75, multiple chronic conditions. Most doctors wouldn't even want to walk through the waiting room, that it would terrify them. It was founded in 1990. When I started working with them in 2010, the 4 founding members were still with the group. You just don't see that much anymore. 12 internal medicine providers, seeing 4,000 patients a month with 12,000 active patient charts. So that tells you right there, that ratio tells you that these patients are in there multiple times a year. These are chronically ill patients. They only did Medicare and PPO. They did no HMO. And they had 3 locations, a full reference laboratory, which is they had the same license as Quest or LabCorp or any of the big labs. I don't know why they had that license, but they did, because it's much harder to get and much harder to maintain. And they did full diagnostic testing, because they're all, internal medicine. They do all their own testing. They don't refer out a lot. They treat their own patients, and that's why it's great to get a referral from internal medicine, because you're going to do a surgery on every patient that walks through your door. So the first question, just to kind of get a feel for where everybody's level of confidence is, that your HIT systems, regardless of environment, will support a value-based payment needs, ACO or bundled payments. A is very confident, B is somewhat confident, C is not very confident, and D is unsure. And there are people in the room. You got your phone out, so we got at least one vote. Okay, this crowd is way too confident. I'm going to scare you. The last class needed a little bit of encouragement. We're just going to scare you. Or is this 67? Is that right? That's a good question. Is that the last one? Okay. Somebody needed to reload in between. Well, in any case, They ended up being confident because they weren't that confident when I left them. So I'm not sure I buy off on that result. So the first gap and challenge is obviously the one we see every day, which is EHRs are typically siloed. They lack the functionality to exchange patient medical record access across settings. For those of you in the hospital, sometimes between floors. Delays in moving from a fee-for-service to a value-based payment create gap between the value and the return on investment of HIT. Basically, if you're not participating with an ACO or you're not participating in bundled payments, for example, some hospitals providers are avoiding bundled payments. Those of you who do joints, you're not going to have a choice come January because joints are mandatory in Las Vegas and a few other places. For the people on the internet, Texas, you're in the same boat as us. You cannot get away from value-based contracting. Bundled payments are the DRGs of our generation. We're going to have to learn how to figure it out. And information and information technology is going to be the magic bullet in this scenario. New payment models provide opportunities for nursing homes and home health agencies to improve the coordination of care through HIT adoption. Really, the battle for bundled payments is going to be won in the post-acute arena, in large part. Your joints, all of your CVAs, all of your sepsis, those are going to be won in SNFs across your community and home health agencies, improving their level of service and communication, both downstream to the outpatient physician practice, but also upstream to your SNF partners who might be able to take that patient back rather than sending them to the ER. So that's part of the conversation here. So going back to internal medicine associates, mind you, this is an old school internal medicine practice. I say that because short of stone tablets, it was all paper. The doctors didn't, I don't even know that all of them had computers. So getting to meaningful use was an epic task. And so you're talking about, when you think about the number of things you have to do to achieve meaningful use phase one, CPOE, allergy and drug techs, problem list, active diagnosis, e-prescribe, maintaining your drug list and key demographics. The implementation involves multiple people within the office, most notably front office and medical assisting staff for you folks in the hospital and home health care to be your nurses, but getting them to record all this stuff electronically, whether it's vital signs, smoking status, clinical quality measures, or you have to institute one clinical decision rule where you're going to change the way you practice based on evidence-based medicine. Getting patients a photo or a copy of their electronic medical records. So everybody talks about how do you get your patients engaged, and you see that the number of patients accessing their chart or speaking to their physician electronically continues to rise. But in an internal medicine practice, how do you get a 75-year-old person how to log in and open an account for your EMR so that they can look up their lab work? It's surprisingly difficult, but it's something that we all have to solve. And then providing a clinical summary, giving the patient, this is what happened, because they may not be good historians, or their spouse or their family member may want to know what went on in the office as a communication. Value-based contracting for me comes down to the 90-10 rule. 90-10 rule is the 10% sickest patients are going to cost you 50 cents on the dollar in healthcare spending. That may be somewhat evident within Medicare, but it's actually true for any patient population. I've looked at it for self-funded groups. I've looked at it for PPOs. Does not matter. 10% of your patients are going to cost you 50% of your money. What are the 10% made up of? Episodic care patients. You get a total hip, you get a cabbage, you go back to your regular life. May not get back into a high-cost area with it for 10 years. You have end-of-life care patients. Either the patient or their doctor don't know this is their last year of life, or if they do, they're going to pursue all avenues of treatment. And we know how much we overspend on end-of-life issues. And then you have the patients that live there, your chronic care patients. This was really my wheelhouse in terms of the doctors and the people that I was working for, because this was our patient population, was the chronic care patients. Actually, all three were their patient population. So that's why, one of the reasons why I actually went after the ACO environment. So I am a ACO, as mentioned earlier, January 2013 cohort. I did not want a bunch of people to try and corral. Internists are a fairly lonely bunch. They don't gather in large numbers typically because they are rugged individualists and do not take direction easily. Herding cats is often used on them, and it would be accurate. If there are any internists out there in the internet world, forgive me. We had 5,800 patients assigned to us. We actually had twice that number that were parts of the practice, but they didn't come on often enough to qualify for Medicare's Byzantine assignment methodology. The ACO, actually, if the doctor wasn't on the HIE, Healthy Nevada here locally, the ACO actually paid for them to get onto the HIE. The first toughest part is reporting on the 33 criteria that Medicare makes us track. Some of them are related to cost, some of them are related to quality initiatives. In performance year one, they save $3.65 million. Shared savings is exactly what it sounds like. 50% stays with Medicare and 50% goes to the doctors. Performance year two, they had $3.1 million in savings, and they successfully reported in the 33 criteria. However, each performance year, the first year you just report, second year you have to report and achieve a certain score within that reporting. We missed CHF by one patient. So we would have had $1.55 million. We actually ended up getting $1.2 million, so CHF cost me about $350,000, which is a painful thing to go through. So HIT in an ACO environment. Mind you, these are all 33 criteria. These are the 2014 criteria, not the 2015, for those of you running an ACO. But you can see how many of these would actually be benefited in terms of having access to good HIT, or in our case, a health information exchange. The first 7 are your HCAP scores, but having access to health promotion education, how well your doctors communicate, that would be benefited. Anything having to do with lab results or radiology results. We transmitted 100% of those electronically. So quite frankly, when you're reporting, I had 2,400 charts to look at, and actually physically, I verified all my results. I actually opened every single chart. We had 13,000 individual line items to audit in 2,400 charts, and they give you about 6 weeks to do it. So I finished with 36 hours to go. I did not know if I would make it as a week out. I told the doctors, I really don't know if I'm going to make it in time. I absolutely would not have made it in time without my HIE, so that much, there's plenty of credit to go around for the ACO success. But what I found is, once you start providing all this information to the doctors, they actually crave it. I'm like an information crack dealer, because my doctors now, going from paper to electronic, the first thing they go to is their taskbar. Because if they don't have their labs in radiology, the number of times I get a 7 a.m. text saying the lab feed is down or whatever, I'm a pain to my HIE partners, because I'm the first one to call to complain, because my doctors hit me before anybody else has reached their office, reached their desk. So here's a poll question. How many of you in this cohort of the afternoon session currently are using your HIE data to view a patient's healthcare record? A is HIE data feeds directly into my EHR every day, once a week, once a month, less than once a month, or not applicable because you're currently not connected to an HIE. So go ahead and respond to 22333. I'm sure that everybody will be putting A or B. Let's see. Well, we actually have, the last cohort was less. We had a lot that weren't connected. Those are actually pretty good numbers. Do you think that's the last one?
Yes.
Okay. Is that where we ended up? Okay, well, I don't know how to turn this thing up. I'll just stand closer to it. Excuse me. So on the ACO implementation, I wanted to give you an example of the types of obstacles we had to overcome, because one of the things that you need in order to be good at HIT implementation is understanding. So in laboratory values, there are very strict requirements with COLA, who is the governing agency for all laboratories across the country. So the COLA determines how the report is presented to the physician. And the report has to meet certain COLA requirements for formatting. So when you're transmitting things through an HIE, the most unlikely of things will trip you up. For example, on LDL values, most of you know that it's micrograms per deciliter. But in the lab, they shorten that with a little Greek mu letter. Computers don't know what to do with old Greek letters, so it would kick it out. A1C values, when you put a percentage at the end of something, same thing with what's considered normal ranges. Surprisingly enough, Quest, LabCorp, nobody agrees on what a normal range is. I don't know if you've ever looked at what is considered normal, but it affects your red flag values, your critical values. When do you call the doctor? Pick up the phone and call them right now. Those sorts of things, when you try to cram them through an IT system without the human intervention, trying to get them to go through. What it took was, I ran a report for that individual value, for every lab that we do, ran it through the system, verified it with my medical director, he certified it, and we started transmitting. So it takes a little bit of work, takes a little bit of diligence, but basically it works. The mammography requirement. For an ACO, you do not qualify for the mammography, even though they bill Medicare, Medicare's paid the bill, and they know that the patient got their mammogram. Fact of the matter is unless the report is signed off and in the chart, even though it's an electronic signature, you don't qualify for the criteria. So you have report routing issues, all the other stuff. I got to overcome your physician, resistance and what have you. But the thing that's interesting is it ultimately changes referral patterns. So what we found is the two groups that aggressively pursued HIE got all their business. So then we go to BPCI. So everybody's talking about bundle. I don't know if everybody's talking about, in my world, everybody's talking about bundled payments. Bundled payments are actually the 90-10 rule in microcosm, because you've got, as you guys learned in earlier sessions, you got 48 bundles with 179 DRGs. And essentially, this is going to be the payment methodology of the future. So what are you doing? You're taking those big episodes of care, whether it's part of a chronic patient's treatment or whether it's just one episode on a generally healthy patient. These are the patients that are going to cost a lot this year. When I started doing the research on transitions of care to assist you in your BPCI plan and network development, I was actually shocked more by the poor provider communication that we currently have in place to help our patients navigate the system. Medicare patients see an average of 2 primary care and 5 specialists in a 2-year period, and patients with chronic conditions see up to 16 physicians within 1 year. 80% of serious medical errors involve miscommunication during the handoff between medical providers. 1 in 3 patients discharged home do not see a physician within 30 days of discharge. That item alone will save you more readmissions than anything, and I'll describe that in a later real-life example of work we've done with a local area hospital. Ineffective care. Up to 36% of adults have inadequate health literacy to understand basic health information. When you're discharging a patient from the hospital, they will sign anything to leave the building. So the education needs to happen either on your floors or somewhere afterwards, which is why I push the physician visit post-discharge. Because whatever they didn't learn from the discharge planner, they're going to need to learn from somebody. 25% of readmissions are for conditions unrelated to those on the initial admission, and up to 50% of readmissions are related to social problems and inadequate access to community resources. We're not thinking about transportation. How do you get them their prescription? Those kinds of things. So HIT and BPCI. The first one, I just decided to cut straight to the chase because I figured I'd have a couple of nurses in the room. Med reconciliations. So I got 50 docs in acute care facilities around town. I got 3 nocturnist programs. So how happy do you think one of my docs is doing a med reconciliation at 3 o'clock in the morning at Sunrise Hospital with 50 people waiting to go up to the stairs, people lining the hallways and 10 ambulances waiting to drop their patients off. And we're sitting here asking a patient, have you taken your blood pressure meds, and when the last time you filled the prescription? This is something that can be done in the blink of an eye with an HIE. I actually beg my hospitals on a routine basis to get on an HIE so that my docs could do this in 5 minutes rather than the 20 minutes it currently takes. The other is comparative imaging. For God's sakes, can we stop working the same patient up for chest pain? I had an internist I saw at an event, and he said, when are they going to figure out a way for me not to have the same patient get a full workup for chest pain 5 times? Readmissions, chronic conditions, ultimately, we can shorten these, we can avoid these if we have information from the prior admission. Having the e-prescribe doesn't solve my biggest problem, which is pain scripts. You know, so a doc forgets to sign them or send them with the transfer summary, but that's a big pain. PCP communication, be nice to make that a little bit easier, provide a little bit more information about the inpatient stay. But the big one is obviously the discharge or transfer summaries to the skilled nursing facilities in particular. Drives us crazy because I got doctors at either end of the transaction, and it still will trip us up. Because if you don't have a discharge summary and or transfer summary, you don't have the prescription. Not having the prescriptions, particularly for the pain meds, causes more readmits than just about any other single item. It's purely administrative. It's not really clinical. It's somebody not checking ahead of time. So those sorts of things, we actually develop workarounds ourselves in order to deal with these issues. I personally have an entire department that coordinates and makes sure that the patient has a PCP appointment. Do they understand their scripts? Did the home health nurse show up? Locally, I have a care coordinator to make sure that the SNF gets the discharge summary. All of this stuff should be automated in an electronic environment, or at least in a best case scenario. But all of these things are going to be what's going to make your HIT work for you in a BPCI environment. Just to give you a quick case study, we took over a local general acute care hospital, no OB unit, older middle income patient population. Took over 100% of the ER call. We had an average daily census of about 110 patients. In the first 7 months of the year, the average length of stay is down by half a day, which for any of, go ask your local hospital CEO how happy he was. But more importantly, the all-cause readmission is below 11%, which is about almost a 40% reduction. The condition-specific readmits, COPD, pneumonia, and AMIs were 0. Didn't have one through the first 7 months of the year. And CHF, out of over 500 cases, we had 4 readmits using this strategy, which is largely educating the patient, making sure they got a PCP appointment, make sure that their home health agency gets out there quickly. So we got a PCP appointment within 3 to 7 days. Keep them out for a week, you'll keep them out for a month. Keep them out for a month, you'll keep them out for 3. A narrow network of LTAC, we push them hard on bedside procedures, expanding their capabilities, getting GI and other consultants available in their LTACs, and they really stepped up. And the ones that did, they're the ones getting the business. We narrowed the network of SNFs, focused on facilities with low RTA and length of stay. But the other part is they need to be able to feed us back the same dashboards we live with in the acute care environment. Is they need to be able to tell us what's your fall risk, what's your psychotropic drug utilization, what quality programs are you working on, so that we can match up our needs in the acutes to make sure they don't come back. In terms of home health care, is rapid response, whether it's safety checks and IV patients on day 1, but it's really about changing your routing. Make sure that your new patients are the first patients on the docket when you're rounding on them, just to make sure you try to keep the shortest time possible from the time they left the hospital to the time your nurse gets to their home. We obviously low RTA, but the biggest thing is an active medical director. Home health agencies got nurses with eyes on patients. Give me a clinician in front of a patient before any other thing, and I'm going to make money off of that transaction. Big thing is to have an active medical director and have alternate sites of care that you can communicate with electronically. If they've got a 3-day qualifying stay, I can send them to a SNF rather than back to the ER, as long as we have the communication taking place. So that's basically been our strategy. Unfortunately, we're a little bit early into the system to figure out whether we're actually saving them money. In terms of doing the transitional care management, part of the research, I added these because each of these represents a different style of how to approach transitions in care. Some of them are focused on acute care, some are on SNF, and some of them actually include home health. So these all will present different scenarios and solutions that each person here or listening in might be able to use for your individual situation. And then I include the references for the various statistics, mostly because I'm kind of a nerd, but also these also provide, if you want to go back and actually look up the references, they might provide a way for you to customize your own solution and how to deploy health IT and strengthen your transitions in care. Wyatt?
Thank you, Mike. Thank you, Mike. Great experience, a wealth of knowledge, having been through some of these challenges and along this journey. Thank you for sharing with us. Well, we want to close out this session diving into a little bit of specific strategy for using health IT. There are multiple tools, some of which are listed on this slide, but the strategy or tool that I want to talk about is the annual wellness visit. It came up during the plenary session as a potential payment process for primary care providers to really engage with their patients. I recognize that not all in the audience today this will apply to directly, but as we step through it, consider similarities in your settings and processes, as I believe that health IT can be leveraged regardless of setting to increase patient engagement and population management and improve process reliability. And in the current environment, it can increase revenue and better prepare our organizations to support value-based payment in the long term. So, sorry, jump ahead here. So we had a poll As we know, the polls aren't currently working. Actually, maybe they are. Let's give a test if anybody wants to respond. This one, the other ones told us they weren't active, so maybe this one is active. So let's go ahead and see if you can respond to this poll. If you can text 222-333, text to the number 222-333, and give us your response. Yes, there it is. It is active. Give us your response as to whether you understand and are participating in the annual wellness visit in your practice. Again, many of you might be the not applicable, but we want to know that in our audience as well. So we'll give just a moment for that to fill up. Excellent. So we're getting some responses now up into 17. And it looks like the majority are actually are aware of and implementing the Medicare annual wellness visit in their practice. We have a few that haven't yet, but are aware of. And then again, we recognize it's not directly applicable to all settings. We provide the next two slides, so thank you for the responses in the poll. Helps us understand our audience. I provide the next two slides as reference for what is included in the annual wellness visit and under the preventive services that should be considered in the written screening schedule. So these are areas that, again, in your different settings, there's probably an element of a risk assessment. There's probably an element of medical and family history that you're going to engage with your patients in. This annual wellness visit is a great opportunity to bring in mental health, at least at the element of depression risk factors with your patients. And then can move us into functional ability, level of safety, and then again, the preventive services and helping develop a plan and offering that support. So again, the second slide I won't spend any time on except to say you can reference it afterwards to see the various areas that you can consider for preventive services for Medicare patients. So to most effectively utilize the annual wellness visit or any element of health IT, we should consider how our systems, our health IT systems, support our engagement level with our patients, with the goal of increasing our engagement level, at least to get patients in for the visit and to support their preventive assessment and screening. So, likely in any care setting, but most specifically in primary care, there's three potential levels of engagement with our current patients. Fully engaged, those are likely the ones with a chronic condition that we're following up with regularly, making sure they're getting the tests and screenings that they need. The semi-engaged would be those that we see on a somewhat regular basis, but for more acute care situations. I see my PCP for sinus infection all too often, unfortunately. But and then the lowest level there of the not engaged, meaning they might be on our list somewhere, but we haven't engaged with them in at least a 12-month period. With the support of Health IT, we can pull data, pull information that allows us to see our various pools of or populations of patients. We can run registry reports or patient lists that allow us to know where they are at currently, and then we can develop a strategy to reach out to them and engage. Phone calls to educate and schedule the annual wellness visit, or mailers with educational pieces on the value of and process for the annual wellness visit, and asking them to contact your office to schedule this visit. Keep in mind that it's an opportunity to further engage, again, with wherever your patients are at, finding ways to engage with them, bring them into the office, and if you haven't already done so, consider this as one of your areas of action today. Another element that Health IT can support is bringing in Health IT to make our process more reliable. And if you've attended the other two sessions, which you probably have, you've heard of both of these elements. But I want to bring it down to what Health IT can do to support. So in the process reliability, we can build in reminders and clinical decision support while they're there in the office or when they're calling in to schedule an appointment. We can set triggers or reminders to get them in to schedule that annual wellness visit for patients, again, based on the query. They're over 60, in the age of Medicare, and have not been seen for an annual wellness visit within 12 months. As the requirements for the annual wellness visit are specific and can potentially cause difficulties, we recommend setting up templates or checklists that help design your workflow to create, to make sure we document appropriately this visit, to capture the assessments, the histories, the depression and risk factors. Ultimately, Health IT can support the selection of appropriate preventive care services from that long list that Medicare gave us, and again, make sure it's documented appropriately. Lastly, through Health IT, we can empower patients with education materials made available through patient portals, as well as treatment options being provided to the patient while they're there with the provider in the room, or sharing through patient portals after the visit. Again, using alerts and reminders, setting up templates, and using Health IT to empower and engage with patients should be on your list for consideration of where you're at with your Health IT in your organization. We've covered a lot in today's session on Health IT, so to try to briefly summarize, we have discussed emerging trends in Health IT focused on new models of care delivery. We've talked opportunities to align your Health IT strategy with alternate payment models, and using Health IT to improve patient engagement and process reliability to get paid for providing assessments and preventive care today through this mechanism of the annual wellness visit. Now, we encourage you to be a change agent in your organization by taking action to help assess strategies and deployment of Health IT, aligning to support new care delivery and payment models, all with the goal of improving patient care. In closing, I want to refer to the words of Dr. John Halamka in a post on his blog titled Life as a Healthcare CIO. He says, at this moment in our society, there tends to be a general proclivity to be a criticizer rather than a doer, to tear down rather than build up, and to have hearings instead of taking individual action. My view is that we must believe in incremental progress, communicate broadly, and focus on our trajectory, not our position. He referred to his own family's experience with healthcare data in the past 10 years. He said, at age 53, my personal medical data is electronic. That was not true when I was 43. At age 22, he continued, my daughter has never encountered a paper-based record as an adult. She has always had to access has always had access to 100% of her healthcare data on her iPhone. That was certainly not the case for me. I look at the experience of 3 generations of my family. The trajectory of IT over the past 10 years has been overwhelmingly positive. The next 10 years will continue to improve data liquidity, patient access, and usability. Let's all be doers. Our position will be imperfect because there will always be room for improvement. However, looking back after years of effort, I can say that our trajectory vanquished many IT dragons along the way. Are we there yet? No. But I am excited, as Dr. Halamka, to watch as national, regional, and local partnerships and collaboration will continue to galvanize the efforts to improve current systems and to be more interoperable, user-friendly, and patient-centered, person-centered. Let's be the doers that Dr. Halamka referred to in our sphere of influence and continue to vanquish IT dragons on our journey to incremental improvement in our organization and towards the goal of the ideal healthcare system. Thank you. Now we have just a couple of minutes. We'd like to take some questions. I'll invite Mike to come back up here. So if you haven't already submitted any questions, feel free to write them on the cards, or we can take hands in the room. But also, we'll take questions through the chat function. So are there any questions in the room? Okay. Too late. We've run you ragged here. Let's just see if there's any questions. Looks like we've got a comment coming in from Utah. The question was, are there any questions? We fooled them as well. Okay. Give it just one more moment. Okay. Well, thank you again for your time today. We will now move into the last session, which is on action planning and evaluation. So we ask for just a few more minutes of your time as we try to pull the slides back up. Right there. Okay. That's why they weren't active. I apologize as I scroll through these very quickly. Somehow we jumped back to the beginning. Here we go. Okay, action planning and evaluations. We will now transition into the final section of our event today, which is about taking action and helping us to evaluate this event. So we ask you to complete your own plan for action based on what you learned today. Develop an action plan that results in change or a step toward transformation of the healthcare system. Today you are introduced to several new key strategies that you can implement within your organization or facility. Think about what stuck out to you. What were those aha moments that you had today? On pages 11 and 12 of your Change Agent Action Book, you'll find the action plan. Step 1 is to pick an action you can implement to improve care delivery. Page 11 lists ideas for action and potential measurement ideas as well. These are only examples. Please use those ideas that you've come up with throughout the day. Step 2 will be actually to fill out on page 12 a little bit more about your action plan. However, before we dive into that, we want to review and share your ideas at your table or in the chat. So please take just a couple of minutes to share ideas with your neighbor. So turn around, turn to your neighbor at your side, share with them one or two ideas that you had that might help them remember those moments, those aha moments for them. So take a couple of minutes and we'll come back. Online participants, we'd love to hear your ideas as well through the chat. Okay, if our audience here in Nevada is any indication, I think people are just ready to take action. So we're going to jump to the next step. As you complete, sorry, I went too far, go ahead and take action. So go to page 11 and 12 in your workbook, write down your ideas. We recognize that the goal is really to take this back to your organization, to share it with your team, and develop the true plan with your team, not in individual today. But as you make a few notes that will give you information to take back, then we want you to share that with us. So we'll take 5 minutes now, allow you to work individually, filling out pages 11 and 12 with your ideas. There are facilitators in each of the rooms. We ask those facilitators to engage with your neighbors and make sure they have what they need to help fill out this action plan. couple of ideas that I'll share coming in through the chat. As a new manager, I will be using the teach back method to implement proper training and understanding. Also, the 3 good things I will use to improve morale during the training process. Some good ideas. What we'd like to do is now we want to capture those wonderful ideas. We want to hear your plan of action. Please complete the action plan summary and tell us what you plan to implement. You should have a paper on your table in front of you that looks like this document. It says action plan at the top. Please share with us your thoughts, your ideas. If interested, we can follow up and see if there's additional support or resources that Health Insight or our partners can bring to bear to help support you. We want to hear what you've been able to put into motion over time. We're always looking for stories of improvement to share with the Learning in Action Network through newsletters and on our website. Our in-person participants, please fill out the paper and leave it with us, or submit via mobile device using the QR code. Virtual participants, please submit using the survey link in the chat box, or again, the QR code. I'll give you just a couple more minutes. I will just mention that as we continue the Learning in Action Network activities over the course of the year, we want to know what other areas you're interested in or what areas you want more information about so we can bring those to you. So please mark those boxes that are applicable. Okay, and we ask you to continue to work on sharing with us your action plans and developing those as you have opportunity here. But we do want to now move into the final step that we're asking for your feedback. Before you leave today, we ask that you complete an evaluation. We want to know about your experience today so that we can improve for the next Change Agent Learning and Action Network activity. We would like you to complete the evaluation for each of the sessions that you attended today. The plenary session, if you haven't already completed that one, as well as each of the breakout sessions. In person, please complete the evaluation on the table or the QR code to access the evaluation on a mobile device. Online, click the link provided on the screen, or again, use the QR code. Also, for those needing continuing medical education credits, you are asked to complete the CME portion of the evaluation as well. All others can leave that section blank if they desire. Okay, and lastly, we want to invite you to continue to stay engaged with this Learning in Action Network. The first of our quarterly Change Agent LAN webinars will be coming in January. Innovative Management of Patients with Chronic Conditions and Complex Needs. Watch your inbox in December for more details and to register. Thank you again for participating in our Change Agents Learning in Action Network event today. We invite you to be the change. Find ways to take action on what you've learned today. Best of luck with those action plans and supporting the change in your organization. Thanks again.